I noticed that 56% of your expenses are for short-term motel stays, and only 18% is permanent housing. Would it be more expensive to have permanent housing if permanent housing was available? Or would you save money if there was a way to actually secure enough permanent housing for people?
I think what you're seeing here in these specific results is because you're seeing the very start of the program, and as Chloe was mentioning, Seattle does have a housing crisis, and so the time that it takes to actually get people housed can sometimes be a significant amount of time. People are on waiting lists for over a year. So the results that you're seeing are really reflective of a point in time analyses, and I expect that over the course of the relationships that REACH has with the housing providers in Seattle, and as we work together to figure out more housing solutions, that we would see some of these numbers shifting. So
thank you. Thank you. It just struck me that it might be actually cost effective to build housing.
I would very strongly argue that it would be cost effective, particularly in these this sample where we're seeing such a high proportion going to the motel and shelter stays, that actually permanent supportive housing would be a much more compelling and cost savings approach. That would be my hypothesis based on the research I've done. Yeah.
And my other question, and I don't know if this would be for Mr. Europe, for Ms. Gale, can you describe more about what Evergreen Services does and how much you had to augment their budget? I gather you had one service provider that then accessed all the other existing client needs. But when I look at that, it seems like that would mean you'd have to get a huge boost in service providers' budget as startup costs.
What was the second half of your question?
It's how Evergreen Services provides the services. Are you a broker, in other words? And how much of a boost did your budget have to get so that you could perform that role? Because that would be a very significant upfront cost.
Yeah, I'll say this. I think what's not reflected here is that there are a lot of leveraged services. So you see there's nothing there for treatment. And that's because with ACA coming in, we were able to, most of the folks that we worked with were then eligible for Medicaid funds, and then they could access mental health and substance use treatment services through the system that way. So we did, I think a lot of the initial startup costs are around a lot of the organizational leadership structure that needed to happen, and then us building out the infrastructure. All of our staff have cell phones. The police officers now all have cell phones so that we're able to text each other in real time. We have vans so that we can go find people and we can transport people easily. So there's a certain amount of infrastructure that had to come up front in order to, does that answer your question?
Well, did your budget double? That's what I'm actually interested in.
She's trying to get a sense of scope.
So
Yeah.
let me step in just for a second
Some
here.
of us are on the budget committee.
Yes.
Right. So
To know the sense of Jim saying don't pay attention.
So we were building this airplane while we were flying it.
Yeah.
And so one of the things that we did when we implemented LEAD was we wanted to make sure that individuals that got into LEAD would not fail due to a lack of resources, because that has been what had consistently been going on their entire lives. And so we wanted to make sure that individuals that got diverted into LEAD would receive the same level of care and treatment that they would if they were from very privileged backgrounds, that if they were folks that could afford to pay for these services themselves. So what we were asking Evergreen Treatment Services to do was to pay for those services as if they were the family member, basically. They're the parent of this individual, and they're going to get them, you know, housing, a bus pass, clothing, food, place to stay, drug treatment, and mental health care. So we limited the number of individuals that came into LEAD very intentionally for the first couple of years because we had no idea of how much it was going to cost. So that red light, green light day thing that Seema mentioned, that was a way of filtering people entering into LEAD until we could get some sort of handle on how much it would cost. And we did it the most expensive way possible because we were spending money left and right. And we're asking Evergreen, lots of conversations between Chloe and myself.
Yeah, I think they asked us really to think how could we operate as a wealthy family trying to take care of your child and really do your systems entirely different. So we came with this kind of crazy out of the box thinking. So for instance, one example of that is initially we had all this funding and we said, well, let's try putting everybody in motels. Right? Oh, we've got 85% are homeless. Let's put everybody in a motel. And what we learned was over time that, you know, the crack dealing that was going on downtown was now moving over to the motel. And we hadn't seen a lot of improvement in the behavior or the community. So we became a lot more selective about how we use motel spending. So the giant curve you see is our learning curve, I think, a lot. As we were moving forward, we really wanted to be creative, and then we wanted to keep the best practices as we move forward. So now, for motels, we use it for medical respite, we use it for a linkage to service, we use it to get somebody to an appointment, but we don't just have an everybody gets a motel whenever they want policy. And I would say now, as we have stabilized our services, they really are consistent with what we have done with our health department programming. Most of our rest of our programming is paid for through the health department. And as we are able to leverage kind of housing, medical care from primary care providers and Medicaid funding, it now is really coming into line with what we're using in our other programs. We do still need the flexibility of the resources to fill in gaps. So I think but it's not a crazy expensive program relative to the other homeless programs we're delivering.
Has there been an increase in the community's investment in services like treatment or housing as a result? Because if you don't have enough treatment slots, you can't be...
So a little bit of yes, and hopefully a lot more yes coming down the line. LEAD has highlighted systemic barriers, and everyone is, I mean, when people hear that there's a 60-day waiting list to get someone into inpatient treatment, that person wants inpatient treatment today, and you're saying 2 months from now, we might be able to get you in. That becomes a compelling argument for dealing with some of the systemic barriers. And so we are having conversations locally about what we can do to best address that.
Okay, thank you. But you still end up with a basic cost analysis that says it's about $2,000 a year for a LEAD participant as opposed to $5,000 a year?
It costs $2,100 less per LEAD participant and $5,600 or so more for the control group.
Okay, so you're basically saving overall a very large amount of money, which is interesting because you have better human outcomes. Now in California, we've tried to devise formulas for things like this so that we share the savings. And I think if we did anything like this, we'd want a way to reinvest the savings into more services so you could serve more people.
When I heard you mention that, I thought that was an excellent way to figure out what the cost savings actually are, put it into programs and services that are going to ultimately support the people that need the most help.
Right.
And the challenge with that, what we have to figure out is because so much of the funding is siloed, how do we take money from reentry and fund social services on the other side. So that's
Yeah.
the challenge I think we encounter, or reentry
Right.
and housing, or whatever the case is.
Right. Well, thank you very much. I don't know if there are other questions, but I notice it's almost noon and the senators have to be somewhere else, or some of us, at noon. And I did want to see if there were are there comments from the public? If there are comments from the public, please come up.
Just go to the mic. Just go to the mic.
Good morning, members. Great to be here. My name is Lynn Lyman. I'm the State Director for the Drug Policy Alliance. And I just briefly wanted to first thank Senator Hancock and Senator Mitchell for co-hosting this hearing. We've been wanting to do this for a few years and really appreciate all the support we've gotten from you, Senator Hancock, and your committee staff. And it was also wonderful to have the Senator and Assemblyman Joan Sawyer with us in D.C. last summer. We had a lot of fun. We learned a lot. I did want to tell you that we are beginning LEAD already without sort of the official support of the state legislature locally on the ground. We have a pilot just about to take off in the San Francisco Bay Area with San Francisco BART Police, as well as the district attorney there and SFPD and the sheriff. It's going to be very interesting collaboration. In Los Angeles, we've been working in South LA and out in the Valley. Our best partner in the LA region is LAPD. They have sent folks up to Seattle to see it for themselves. LAPD is fully on board with this and bringing the district attorney's office on and everybody else. But it's been great to have the Seattle delegation be here to kind of give a first-hand report on this. So just want to say that Drug Policy Alliance is doing this here in California and all across the country. We started the second site in Santa Fe, New Mexico in 2014. We kicked off Albany a few months ago. We're hoping California gets in there next.
So when you say that you've got the pilots in these LA, San Francisco, without the legislature taking action, how is that happening? It's all local resources?
So none of these, so these are all exploratory groups that are getting ready to move forward. The San Francisco one is the closest one to signing an MOU, which is sort of the first official step in this process, is that all those stakeholders sign an MOU about their different roles.
Amongst themselves.
And so it is not necessary, although it would help to have legislative authority to do this, it is not required. So this really is a type of innovation that can happen locally in communities. Of course, having the legislative authority and having the funding would go a long way. But for example, in San Francisco, the Public Health Department has committed the funds to get this started.
To the tune of how much?
An initial allotment of, I think, around $200,000 to pay for the case management and the project manager. We assume, as you heard from Chloe and Seema and others, that much of the costs are going to be able to be covered by the ACA.
And your Seattle sample's about 330. What will the San Francisco?
So they're going to start. They're going to start small in one sort of BART station first, and then expand out. And the same thing in Los Angeles. We wanted to start really small in South LA. We're in 2 parks, just getting going there. It's not quite the LEAD model there. It's very similar, but the city attorney wanted to do something slightly different. But we're looking at University Park and one other park in the Lamert Park's the other one. Thank you, Unisys. Yeah, so we're in your district. Deputy Chief Bill Scott, who you may know, he's the one who went to Seattle. He came to D.C. with us. He's been our champion at LAPD, and he's brought Chief Beck fully on board with this.
John Bowders, our Californians for Safety and Justice. Just wanted to thank both the co-chairs for having this hearing today and the members and staff who have listened and participated. We're very pleased to be in partnership with our friends at the Drug Policy Alliance, and I know we have a number of very interested partners in the law enforcement community as well who, like you heard Jim Pugil say earlier, have really seen the value in this. And we would just really encourage you. There will be some additional work being done to talk about how we could make this a possible pilot program in the budget this year, and I'm happy to continue those conversations with you going forward. Thank you for your time.
Okay, well, thank you very much. It's probably just about 12:02, and hopefully this is just the beginning of the conversation. It's wonderful to see social workers and prosecutors at the same table, and good to see solid evaluation, and good to see that there may be a way we can improve human outcomes and save money. So we will be considering all these things as we move forward. And again, thank you so much, people from Seattle, for being here with us. It makes all the difference.